Hello, everyone, and welcome to my presentation, Midwifery and Women's Health in the Last Frontier. And thank you for your patience with all those technical issues. I promise the pictures will be worth it, okay? So I'm Verzone, and today I'm going to talk to you about the unique challenges we face delivering midwifery and obstetric care and women's health services to these rural areas of Alaska. My background in this area is I worked with Sound Central Foundation at the Alaska Native Medical Center as a midwife laborist for several years. And that was the first place I worked when I first moved to Alaska, actually. And then prior to that, I'd been at a migrant farm worker clinic in Southern Oregon. And because I'm dually certified as a family nurse practitioner and a certified nurse midwife, I also worked as an FNP for the Anchorage Rural Health Service, where my husband, who's a physician assistant, and we would fly out together and work in these remote areas for 1 to 2 months at a time. And so that was all great until I had a kid and started freaking out on the small bush plane rides in the winter. But more on that later. So currently, I still work for those organizations on a per diem basis, as well as a midwife hospitalist for the Providence, Alaska Medical Center. And I'm also clinical faculty at the Frontier Nursing University's DNP program. All right, trying to advance there. Okay, and in terms of financial disclosures, I have no financial disclosures, and my primary motivations for doing the public health work are not financial. So I'll be reviewing rural midwifery and obstetric care and perinatal regionalization and discussing some of the unique challenges of this geographically and resource limited state and a lot of these other settings, and some of the really novel health approaches that the health system in Alaska has come up with to respond to the management of high-risk midwifery and OB patients. In Barrow, which is in northern Alaska. So it never sets. You can see it rising, and then it never actually goes below the horizon. We are actually in the opposite of that now. We're heading towards winter solstice. Okay, trying to advance my slide here. Russ, it doesn't seem to be advancing. There we go. I don't know why it's not showing. Is it showing for you guys? And I just can't see it?
I see the slide that says geography quiz.
You're able to see it? Okay, so I think my
Anna, are you still there?
All right, I'm back. Thank you guys. Hopefully this won't have any other tech issues. I just logged off and back in. So in terms of geography, we all think of Texas as being a really big state. But if you look here, compared to Alaska, not so much, okay? And if you look at this slide, these are some fun facts. Alaska is 570,000 square miles. Texas is 260,000. Okay, which is, so Alaska is 2.5 the size of Texas. And so that kind of means like Texas is cute compared to Alaska. So we like to humor those little Texans, right? And Alaska is actually larger than all but 18 sovereign nations. It has more ocean coastline than all of the other US states combined. And Alaska is the only state whose capital city is accessible only by ship or air. So you cannot drive to our state capital. And if the state's westernmost point was superimposed on San Francisco, its easternmost point would be in Jacksonville, Florida. So pretty big. And this is what we're dealing with, right? And so let me see here. Look. Okay. So there are some similarities between Alaska and Hawaii. No kidding. So if you think about how Hawaii's formed, it's this chain of islands, and that's formed by a hotspot underneath the oceanic crust. And as it moves, that hotspot continues to boil up the oceanic crust on top of it. And then as it moves northwesterly, new islands are created in the southeastern portion. So in Hawaii, the big island, Hawaii, is the newest island. And then if we look here at Alaska and the Aleutian Island chain, there are some similarities. So some people think it formed in the same way in terms of these hotspots, but it's actually a different kind of geography where the Pacific plate's diving under the North American plate and in this curved format. So these are actually formed in a subduction zone. But despite these kind of differences, what I found is like flying over Hawaii, there were some similarities to the geography in Alaska with these fluted islands like the Nepali coast. And it looks like my slide is a bit out of order from the ones that you guys uploaded, but I have a picture of me near some waterfalls in Alaska that look a little bit different. There we are. Yeah, so if you can see here, this is not what Hawaii is going to look like, but this is me hanging out at the waterfalls. And believe it or not, the shape of the island here, this is St. Paul, is very similar to that of like Kauai on the Nepali coast. It has these fluted coastlines and whatnot. But what's great about working in Alaska for me is the sense of adventure. And like in St. Paul Island, there was just us, a population of 479 people, and National Geographic expeditions that would come out there to look at the birds, right? There were also a big colony of northern fur seals. And so a lot of great adventures to be had providing healthcare in Alaska. And so it combined both of my passions for adventure and serving the underserved. Okay, another unique thing about Alaska is we kind of have our own language too. And I'm spending some time painting the picture of Alaska here, and it is relevant because we have this very unique culture as well that plays into how we deliver healthcare to our patients. And so, you know, one of the first corrections ever made to me when I moved here was I said, oh, do we ride snowmobiles out to the clinic? And people are like, it's not snowmobile, it's snow machine. And there's also names for non-locals, like, you know, in Mexico, it's gringo, in Hawaii, it's haole, and here it's chachaco. So, you know, like the newcomers are chachaco. And the rest of the United States, we actually call the lower 48, or we even just call it the states. It's almost like Alaska is totally separate. And some other terms we have are like breakup. Breakup is when river ice and sea ice break up. And this actually plays a big role in transportation because for some villages, they're able to get out before breakup. But once breakup happens, they then become isolated and they can no longer leave the villages via the frozen riverways. And it's also a time when the sea ice breaks up. So we refer to this, and the villagers will place bets around this too as to when breakup will take place. And in fall, the first dusting of snow is also called termination dust. All right, another fun fact about Alaska, we are actually the highest ranked state from most to least likely to, like, we're the most likely to survive the zombie apocalypse. If you can see here, like, our ranking for military personnel, veterans, being physically active, martial arts, survival skills, knowledge of zombies, laser tag facilities, gun owners, obesity, lower rates, right? Paintball, Ironman triathlon participants. So, you know, out of our total, like, we rank #1. And so it's really important to know where your state ranks here, in my opinion. So I love how resourceful Alaskans are, right? They're very prepared for a lot of disasters and challenging times. Now, interestingly, these life skills of adaptation and resilience are common to many other communities living in the circumpolar regions. So no matter the country, right, in the circumpolar regions, we see four-wheelers, we see the rituals that take place around the breakup season, we see community events centered around the seasons, around long, dark winters, around gathering berries and whatnot. But we have additional similarities to other circumpolar nations that we're really proud of here in Alaska, and that's especially in regards to our maternal mortality rates, right? So if Alaska was its own country, we would have a maternal morbidity statistic or maternal mortality statistic closer to that of the Netherlands, actually, rather than the rest of the United States. And this might be surprising to a lot of people who might think our statistics would be far worse off, given the vast geographical space and the extremely remote conditions, the transportation and climate challenges. But this presentation is going to help you understand how we went from the worst statistics to the best in the country. So if you look at maternal mortality in developed countries, it's not news anymore that the USA is climbing in its maternal mortality rates and is doing much more poorly than any of the other developed countries that are actually declining in their maternal mortality rates. And this is taken from The Lancet. And I did want to mention that for this slide, only data for 1990, 2000, and 2015 was made available. But the maternal mortality rate in the US is 26.4 at the time of this data collection, and that of the Netherlands is 6.7. Now, take a look here and look at the ratios by state and look at Alaska's, 6.2. So that is really good, right? And this is an average here. So this is like under half the maternal mortality rate of the country's average, right? Or even like a third, or even a quarter, actually. So while Alaska is 2.5 times the size of Texas, right, with vast landscapes, harsh climate that renders some areas unreachable by traditional travel for months at a time, I'd say this isn't too bad, right? So some frontier villages are so underdeveloped that they lack potable water or sewer systems. And these challenges made for a really negative maternal and child health outcome profile until Alaska built a system of perinatal regionalization, which was founded in the 1980s. And it now leads the nation in the way it's addressing these issues. So in the 1980s, Alaska had the second highest mortality rate in the country for babies less than 28 years old. And at its peak, the post-neonatal mortality rate was 7 deaths per 1,000 live births. And today those rates are down to 1.92 deaths per 1,000 live births. This is the lowest post-neonatal death rate in the nation, nearly 0.5% better than the second lowest state, Vermont. And as this slide shows, Alaska Native newborns still die at approximately 3 times the rate of non-native newborns. However, the public health system is still trying to address this healthcare disparity. Now, with perinatal regionalization, this ensures adequate medical and supportive resources in a geographic area to identify, triage, and treat these high-risk mothers and infants. And that totally made this change possible. So in the 80s, when mothers delivered really sick infants too early in many parts of Alaska, the infants often died. And this state had some uniquely challenging circumstances, right? So we came up with these really innovative ideas to address that. And so I'm so excited to show you even more of these. And it's improved piece by piece over the years. So this is a great photo of Billy Joe and Stacy Ray, actually. They were born at the Alaska Native Medical Center. And I love working in Alaska for the people and the unique medicine that we see here. So let's give a little bit of history here, the pre-regionalized history of maternity care in Alaska. So prior to the 80s, like I said, we had the highest maternal mortality rate in the USA, and especially with American Indian and Alaska Natives within Alaska. And there was scanty, if any, prenatal and intrapartum care. So many people were birthing unattended in the bush, and there was minimal access to properly equipped facilities. And the harsh environment, the sheer size of Alaska, and how dispersed the villages are, there were so many limited resources available in the bush, and as well as cultural challenges, all contributing to this poor healthcare access and leading to this high maternal morbidity and mortality rate. And there were also higher rates of preventable neonatal risks that were contributing to low birth weight and infant mortality. So some of these barriers to care can continue. So if you're looking here, we have the geography, the climate, the cultural, the financial, transport, geology, and wildlife. Like, I go out to the bush, and some people, especially of the younger generations, they don't even want to exercise outside because they're afraid of the bears. Whereas with the older generations, being and living with the bear and the moose was part of life, and they were very comfortable, albeit still cautious. And that sort of changed generationally. And then here, this is a ANMC. Here's a picture of a moose, right? That managed to enter the actual hospital. My friend Sally Hansen also has these screenshots of emails that we received through South Central Foundation. So it's like a moose with 2 calves spotted roaming through campus. And moose can actually, especially with 2 calves, can be more dangerous than bears. There are more deaths from moose in Alaska than bear, and so you have to watch out for them, and they can actually, prevent access in some areas if their people are trying to avoid them. And in November of 2018, we also had a 7.2 earthquake. We have lots of earthquakes throughout the year, and I'm from California, so I'm a little more used to this, but the earthquakes here can be big, and they do provide additional challenges as well, especially in the remote areas. Okay, I'm going to skip this slide because it comes up again later. All right, so these are some photos from the city of Utqiagvik, so formerly known as Barrow, so Utqiagvik. It's one of the larger, most modernized remote areas, and it still has many of the challenges described. So this town has about 4,300 people. And it officially changed its name to Utqiagvik on December 1st in 2016, which is, Utqiagvik is the village's traditional Inupiaq name, which means the place for gathering wild roots. And here, the Inupiaq language is found, the Inupiaq culture is also found, and the traditional lifestyle here still includes whaling. Those are actually whale ribs in the upper left corner there, making that arch. And in Utqiagvik and Barrow, formerly known, right, since it's so far north, there are the extremes of light and dark. That photo I showed you earlier was from Barrow. The oil industry has a strong presence here, and so there's a sort of transient population that comes in 2 weeks on and 2 weeks off, and they do shifts that way. And another strong presence is polar bears in town. So if you see there, those are polar bears hanging out with a whale carcass on the beach and polar bear prints. And this is Samuel Simmons Hospital. There's about 30 births a year here. Although for some reason in 2018, there were only 12. But remember that these are not just birthing centers, these are hospitals that are addressing all kinds of needs in the region. So in terms of rural maternal child health in Alaska, as I said, in the 80s, there was this program that began, and this ensured that there could be adequate medical and supportive services in geographic areas to identify, triage, and treat the high-risk mothers and infants, right? And to facilitate the delivery of care. So Dr. Hirschfield, who is a physician I worked with, he's been a part of the development of this program from the beginning. He said in the late 70s and early 80s, the people realized there had to be a better way to deliver care to women so that they had more healthy babies. And then there was this concerted effort between the Alaskan Tribal Health System, Providence Hospital, which is a large hospital in Anchorage, and the whole state to develop this system. And we received Title V maternal and child health block grants for this project, and we apply for them every year on an ongoing basis. So what this grant is it requires all states to report on maternal and child health performance measures and outcomes every year. And so you can check out Alaska's or any state's application on their website. And the perinatal regionalization also includes prenatal care coordination between the villages and referral hospitals, either in the hubs or in Anchorage. So we are doing risk assessments throughout pregnancy for medical and social risks. There are patient education programs. There are village visits by OBs. Sadly, they stopped regular visits of certified nurse-midwives to the bush several years before I arrived, but the OBs still make some regular visits to certain areas. And in that, we also have to anticipate these Alaska-style complications, like weather, the types of transport available. This is the most common, these bush planes are the most common types for the villages. Family members, are they able to travel with the mother when she has to be transported, and those things. So mothers are brought to Anchorage at 36 weeks if they don't have a regional hub hospital available, or if they are considered high-risk OB and have had a previous high-risk pregnancy. And we call this kind of early arrival in Anchorage them being put up in a pre-maternal home. And there's also a vast transportation network that includes local bush pilots, commercial and small plane commuter flights, and commercial jets like Alaska Airlines and other smaller commercial companies, and even assistance from the Coast Guards when we have to do transports in inclement weather. Sometimes we have to get a C-130 in, which is a very big plane. So there are about 700,000 people in the state, 300,000 in Anchorage, 100,000 in the nearby valley, the Mat-Su Valley. And so our catchment area around for the Anchorage hospitals is about 400,000 people. So that's 60% of the state population. And in this area, there's about 10 to 11,000 births a year, and we're seeing steadily increasing volumes in our area, but they do seem to be declining elsewhere in the state. So in 2016, the Alaska Native Medical Center alone had 1,700 births. And for just the Alaska Native or American Indian population, there were 2,400 in the state. And then our other large hospital, Providence, had 3,000. And all other hospitals outside of Providence, or outside of Anchorage rather, cannot deliver at under 36 weeks. So there are transports when needed. Like in some states, giving birth at 34, 35 weeks, no big deal has to happen. But here in Alaska, no other hospitals can deliver at under 36 weeks. And actually those moms and babies have to go to Providence because they're the only ones with a level 3 NICU. And there are also 2 military hospitals, and they had about 700 births last year. So you can see here the distribution of hospitals for deliveries. So when I say regional hubs, I mean that there are hospitals for deliveries, each with varying levels of resources. So, you'll see float planes landing for fishing charters in these areas, but then also those will be taking off with those fishing charter clients, maybe with a pregnant mom to bring her over to a hospital, right? Or someone who delivered and they're coming back to the village. And so in these areas with a hospital, they'll be flown out to a prematernal home if they're high risk a month beforehand, okay? So a lot of the women, they have actually a really good sense of humor about this. There's lots of comments on, oh, it's my chance to go shopping. But the reality is that this is really challenging and uprooting for so many women. And I'll talk more about this later, but there's a lot of boredom and disconnect from family when they have to get uprooted and brought to these prematernal homes. So like everything, aspects of the system have developed that are uniquely Alaskan, but we also have these challenges. So in terms of how this gets paid for, more than 50% of women being transported to a prematernal home are Alaska Native, and their healthcare is covered by the Alaska Native Tribal Healthcare Consortium. And also more than 75% of women being transported are covered by Medicaid. So this coverage pays for both their transport and much of the cost of their stay in the prematernal home. So this is so different from what prenatal care was like in Alaska 30 years ago, right? And that change, according to the American Academy of Pediatrics, says that change alone is responsible for dramatic turnaround, because we used to have the worst infant neonatal mortality rates in the nation, and now the best. So I'm going to skip some of this just because we're a little behind on time due to our tech issues, but I will give you copies to my slides. So here you can also see, compared to the previous slide, I'll just go back again. These are some of the hospitals for deliveries differentiated by public or native or military. And then that's one question, but then what are the hospitals with OR and C-section capability, right? And here there are far fewer, and they are all tend to be more localized to the larger cities. So that's why anything high risk is flown into Anchorage, because or to one of these other regionalized hospitals with OR and C-section capability, even though they may have a hospital nearby. So here's an example of our model. So in the village, there's prenatal care for rural women, and it's kind of a team effort, right? So there's health aides in the rural communities working in those small clinics. And what's great about that system, I'll go into it a little bit later, but it's local youth usually, or maybe mothers, but they're local community members that decide they want to be a community health aid provider, and they get trained in Anchorage. And so they can provide a lot of the care, and it is a team effort. Like, they can call in for consults, there's telehealth and whatnot. And some of the larger village clinics are also staffed with nurse practitioners or physician assistants. There aren't any nurse midwives in the smaller clinics. They are kept in Anchorage. And these providers are vital. They are a part of the communities, and they're key to getting women into initiating prenatal care. And South Central Foundation's OB-GYN department has a rural maternal child health program, RMCH, which includes a dedicated certified nurse midwife who's kind of tracking all of these women that are in the villages, as well as an RN case manager and someone who is the appointment and travel scheduler. Because you can imagine the challenges of bringing women just for their prenatal check, right? Because there aren't that many providers in the villages that are adequately trained in prenatal care. So the key to providing prenatal care to women in these communities is early initiation of the prenatal care and identifying those risk factors and coordinating the visits in Anchorage for provisions of the services that aren't available in the villages. And these rural providers, they shoulder a lot of responsibility with healthcare supervision for the whole village. I mean, they're handling someone coming in with some contractions that maybe aren't in labor or having a little bit of spotting. They're handling plane crashes, bear maulings, everything, right? And so they're trained in prenatal care to verify like just normal progress, and hopefully to identify when things are not normal. But again, they also have ready access to rural maternal child health teams. So because I was a FNP and CNM, if the RMCH team knew I was going out to the village, they would say, could you please see all the pregnant women there? Because no one's been out there and they haven't been to Anchorage, and could you just do a thorough evaluation? And so the goal is to keep the mom and baby dyad in an appropriate level of care while trying to maintain proximity to her community, which is a delicate dance, right? And we're trying to avoid the births occurring in villages without adequate care and someone who's trained to attend to that delivery. And so the prenatal care is reviewed, like maybe the PA or the family nurse practitioner will send in the prenatal charts, and the RMCH midwife will look over the charts and just make some phone calls and whatnot, ask questions. They'll do check-ins as well. And the rural providers report village pregnancies to the RMCH team. And then we have to coordinate all of the visits, right? The trips in for visits and the care in Anchorage, and can be quite a production. Okay, so a little bit more about the CHAP Village Health Aid. So this program is universally accessible for the communities. And this is essentially based off of the community health worker model, right? And so the circumpolar north, where we are a part of, is a really diverse area. Unique people, unique traditions, unique governments, and they share the many challenges of healthcare access all over the world, people that are in the circumpolar area. So it's been found that this model of having a community health worker, and in Alaska, we call it the community health aid provider, being able to provide the basic care in these villages. Like in Sweden and Finland, it's delivered by RNs and nurse-midwives. And in Greenland, they have general practitioners and then a village health worker like Alaska. And in Russia, they have health posts with village health workers. So this is really common in areas that have these unique challenges. And also in the international work I've done, you see this same model in Nepal and in India and in many countries in Africa. So one of the other challenges is the transportation, right? So for example, just the monthly checkup for a pregnant woman can present a huge financial and logistical hurdle if they aren't living within driving range of a medical center or a healthcare clinic. So the trip to a healthcare provider can involve taking a boat or a plane or both, and then a car ride, and may even entail overnight stays because of transportation time from their home to the place where the plane would land, let alone then getting to Anchorage. And so weather is also a huge element in transport options and availability. So even with close follow-up and monitoring, obviously, we can't always predict when someone's going to go into labor. We can't predict the weather, especially in winter. So it can take hours for a medevac plane just to reach a village. And sometimes in the summer, that means boat can be the best because it's a little bit safer than air flights, depending on the time of year. This is a picture of the prematernal home in Anchorage at the Alaska Native Medical Center. So this is where the women would stay, you know, at about 36 weeks or earlier if they're identified to have a high-risk pregnancy and need to come in earlier. And so this type of housing, you know, makes the delivery experience more family-friendly, but, you know, no one's going to pay for the whole family to come out. Most of these women can just bring one person. And so they can stay here, or they can choose to also stay in a nearby hotel, or if they happen to have family members in Anchorage, they can do that. But so many of them don't. And it's a real hardship for women to be away from home and family during this period of time. But the small rural villages aren't equipped to handle the potential complications that can occur with labor and delivery. And this, you know, housing is making a good attempt at it. But, you know, one of the things that we could do in the meantime while working on trying to up-level the access closer to the villages so that this women don't have to be uprooted in this way is to utilize this time to be more effective. There's so much boredom. They like come, they're away from their family, and they're just kind of hanging out for 4 weeks, right? They don't know the area. They don't know what there is to do. And so this could be such a great time for parenting classes, nutrition classes, cooking classes. There's just so much that could be done that isn't done yet. But, you know, so I feel like we haven't really maximized the potential of this. I do just want to emphasize also that while my focus has been with the Alaska Native community, these challenges exist for all women across Alaska. So these are some of photos of my family heading out to go to the bush together. And as I said earlier, I started to get really uncomfortable with the small plane flights, so I don't do that anymore. But here's a photo of us on the bottom going to King Cove, super small plane, very bumpy flight all the time, even in perfectly sunny weather, just because of the shape of the mountains in the region and the topography. Super bumpy flight. Like my patients would cry when I told them they had to get onto a plane to go to Anchorage. And they were not excited about shopping. They were so terrified of this flight, right? And it's like total cowboy pilots who are very skilled though. So the stuff you see on the Discovery Channel about Alaska, it's not just a TV show, right? This is real life stuff. And I remember a patient telling me about her mom, who was a pilot, getting flown out in labor, but the pilot was drunk that was picking her up. She realized he was drunk. So she actually took over flying while she was in labor and flew the plane herself and landed it and everything while she was in active labor because her pilot was too drunk to to fly her. So non-native patients follow a similar path for their babies, right? Any high-risk OB comes out, and then even military, and then other non-native patients living in rural areas. So here you can see the ways different organizations collaborate here. We have the Alaska Native Medical Center, the Rural Maternal Child Health Program, the Family Residency Program, with medical schools, and then we have the centralized nurse-midwives and OB hospitalists that then branch out to a lot of the private practices. And what's key here is I think that there's coordination and collegial support amongst all these organizations, amongst the private hospitals, the native hospitals, the medical schools. There's lots of actually, nurse midwives students also coming to Alaska. We have a lot of frontier students here actually. And then between FQHCs and private clinics, there's wraparound services that address all these needs of the mother-baby dyad. Kind of like banding together in rough weather. Right? Here's a beautiful photo of an Alaska Native family. And, they are living in varied environments, coastal, it could be inland river deltas, which have really extreme weather from super hot in the summers to -60 or worse in the winter, or Arctic tundra regions. And there's a long history of subsistence hunting, fishing, and whaling, and other aspects of traditional lifestyle that we take into consideration when delivering care and doing dietary counseling and whatnot. So these remote areas are mostly made up of Alaska Native people, and there's about 160,000 Alaska Native people in these regions and 229 tribes. Okay. So here's the service area. Again, just an image of the vast regions that do come into Anchorage if there's foreseen complications. And I'll kind of go through some of these a bit more quickly due to our time. But the Indian Health Service is an agency within the Department of Health and Human Services. And the Alaska area Indian Health Service works in conjunction with Alaska Native tribes and tribal organizations to provide these health services. So separate, but they work together. Here's a picture of our campus at the Alaska Native Medical Center. And I just wanted to touch on some of our unique high-risk OB issues with our population. So, on average with diabetes, there's about a 6 to 7% prevalence of gestational diabetes nationwide, about 7 to 15% in IHS, and we're seeing about 13% with the Alaska Native and American Indian population here in Alaska, and about 60% are obese at a new prenatal. And in terms of hypertension, we see lots of hypertension, but no HELP syndrome or severe preeclampsia. Why is that? We're not quite sure. But one of the theories is this substance called ICMIC, and it's also called Black Bull, and it's a smokeless tobacco product. It's used in parts of Alaska, mainly among Alaska Natives. And ICMIC is made using a mixture of tobacco and the ash of a fungus, Phylinus igniarius. And it's informally called punk ash. And they mix this, and it basically it creates nicotine to be available in a freebase form. So it's very addictive, very potent, and is a big contributor to chronic hypertension in the Alaska Native population. So that's one of the theories. We also have high rates of intrahepatic cholestasis of pregnancy. It's very common in the Alaska Native population, up to 5%. Right? Whereas like in the rest of the US, it's much lower. So 1 in 20 births to Alaska Native women are complicated by IHCP. So up to 4.6% of women with ICP will experience an intrauterine death if no medical surveillance or treatment is undertaken. So a lot of this data is derived from a quality assurance project that was started by Dr. Gilson's office at ANMC because he started to notice this high incidence of stillbirths, right? And it's still a significant cause of stillbirths in Alaska Native women. And so we know ICP has a high incidence in certain ethnicities, like in Bolivia and Chile, it's 5%. And in Scandinavian Baltic countries, it's at 2%. And other countries like in Europe, North America, and Australia, it's less than 1%. And there might be obviously some different gene mutations there, but we have not identified them. And then postpartum hemorrhage, we do know that there's a significantly higher proportion of Native Americans, of American Indians, that non-Native women develop a higher rate than non-Native women developing postpartum hemorrhage. So it's at 11.6% versus 7% in one analysis. So Native American origin in one multivariable analysis was an independent predictor of postpartum hemorrhage. And I definitely saw this at ANMC as well. And then high rates of needing social work consult because of the prevalence of domestic violence and substance abuse. Here's our C-section rates. You can see that how low the Alaska Native C-section rate is compared to the US, compared to all Alaskans, and then compared to the Alaska Native population. Needing C-sections is not something that we had to do a lot. And so I was very grateful for the high numbers of uncomplicated vaginal births that we were able to have. I could say so much about the trauma in Alaska and with the Alaska Native population with colonization that has had a ripple effect on so many levels, but there has been a huge movement towards cultural healing. This is a list of so many different programs that are in place to help facilitate that cultural healing, which is contributing to this to these higher risk conditions. I will move through that. I wanted to just show here, you can see the C-section or the C-section rates for the Alaska Native Center. In terms of C-sections, what was our rate here? Oh, it's not showing it here. Okay. I'm going to skip over this then because I want to show you some other pictures. So this is the Bethel area. The Kuskokwim Delta. I'm just going to show you some pictures of the regions that have these regional hubs. So this is in Bethel. They have about 500 births a year. 350 were transported last year out of that 500. In Barrow, also now known as Ukiagik, that they had around 30 births last year and no transports last year. This is the Southeast Alaska Regional Health Consortium. Juneau and Sitka. Sitka had between 50 to 60 births, and about 2 were transported, and they were stable last year. Kodiak Island had about 150 births, no transportations needed. And then here's Dillingham and Bristol Bay. They had 50 births, and 30 of those had to be transported out. This is like in anticipation of not necessarily emergent transports. And then Kotzebue had 70 pregnant women last year, and 30 needed to be transported to Anchorage. Nome, here's a great picture of Nome. This is where the Iditarod ends. You can see the muskox in the picture. They look like little baby woolly mammoths. They're so cute. They had 70 pregnant women and 30 had to be transported out. So, we're facing increasing issues with climate change. A whole entire village, called Newtok has to be relocated because of the melting sea ice and the rising ocean levels. And, we are kind of the canary in the coal mine here, and we need to pay attention. We are seeing a lack of the loss of the traditional lifestyle. We're seeing emerging infectious diseases with urbanization and increasing mobility. Anthrax and toxo are found in moose in Siberia, and we're very close to Siberia. We're seeing increasing rates of TB and syphilis as well. Here's a picture of just women one generation apart. The modern outfits and the change from the traditional lifestyle. Here are our transport rates. You can look at that. And I know I'm running out of time, so I'm sorry about that. I'm just going to kind of go through these slides and show you some of these other images. I just wanted to also emphasize that while our rates are improving, so if you look here, California is an exception to the rest of the United States with numbers falling here. I just really wanted to comment on this, if you could hang in there. But up until 2008, the trend looked like this for California, right? The maternal mortality rate was climbing, and in the US, we were right in the company of Afghanistan, Lesotho, and Swaziland, right, in terms of our rates. After 2008, in California, they really they initiated a program, and look at California's rates dropping. So we can do something. If people prioritizes and pay attention, we can lower these rates. Alaska has done it with the limited resources and huge challenges we have. California, has managed to do it as well, right? They created an alliance for innovation on maternal health to provide support and guidance to these areas. And 19 other states participated in this. So, however, even in California, as in Alaska, while the maternal mortality rate is declining, the African-American women still have 3 to 4 times are more likely to die of complications. And in Alaska, it's the Alaska Native women, right? So those healthcare disparities still exist. Now, if you look here, this is not a accidentally blank slide. Here you can see teeny splotches of color. This gives a good idea of how rural Alaska is. This is the driving times that they have. I mean, these are the only places where you can drive to a hospital in under 60 minutes, right? Not many options. And there are people all over the state. If you have not watched this on Full Frontal, I highly recommend it. You just have to Google Samantha Bee, No Country for Pregnant Women. It's an excellent spoof, but with good data about our current crisis. So in terms of Canada, they are making great strides in keeping care closer to the communities. And I feel like we need to keep an eye out to what they're doing, because they have similar challenges as us in the circumpolar regions, and they're managing to make some great strides in providing care closer to the communities without having to uproot women and move them away. And so I just wanted to plug that. And that's another picture of the prenatal home. I'm going to skip through that. We're almost done. We in Alaska, though, have high increasing rates. We go back and forth between DC being the most sexually diseased area in the US. And so syphilis is on the rise. Family planning, we are really trying to improve that with using LARCs, and also with abortion access. And I just have a few slides on that. So, we have Medicaid coverage of abortion, but laws that affect sex ed. There is a change with the parental consent law that makes it more accessible, as well as the allowance of second trimester abortions. But if you look here, it's really hard to get access. So they're starting to do telemedical abortions in Alaska so that people don't have to fly in for the evaluation. And so this comprises about 1/3 of all, of abortion services in Alaska right now, this telemedical abortion. So I really feel like that's innovative as well. And if you can see here, this is abortion access in the clinic, one per week. One person per week, people are flying in, or people can be flown in 1 time a month, or telemed only. And so that was a summary of some of the things that we do. So thank you for hanging in there with me. This says Kuyana, which means thank you in Yupik. And the Yupik, U means people and Pik means real. So it means the real people. So Kuyana, thank you so much. These are all the people that contributed to my slides. I apologize for going over, but I thank you for hanging in there with me. These are my references. And I will, for those that are still here, I'd be happy to open this up to any questions if we have time. trying to see. I'm not seeing any.
Thank you, Anna. I don't see
Okay,
any
great.
questions initially, but we can hang out for just a minute if people do want to stay. We'll be here for 1 or 2 more minutes and can field any questions, or your email address is also there on the slide. And Dr. Butler has a question, actually.
Yeah. Oh, it's not that it's non-existent, Dr. Butler, in terms of help. It's just that we're not seeing it with the prevalence that we would expect it to be with our high rates of severe hypertension. And so we definitely have HELP syndrome, but we're not seeing it when we see severe hypertension, we're not seeing the concomitant HELP with that, HELP syndrome with that, because we're thinking rather than it being related to preeclampsia or HELP syndrome, it's the use of the tobacco derivative that we were talking about. At least that's one of the rates. In terms of the low rates of C-section, you know, one is that the Alaska Native Medical Center has fully staffed CNMs like round the clock. And so we know that the presence of midwives do decrease the rates of C-section. But I will say, like, it was the only place I've ever worked where a primip would deliver in 20 minutes. Like, it was pretty amazing. I think the general consensus is the vaginal births are very easy and very fast. And the fast part can contribute to the postpartum hemorrhage rates as well. But yeah, I would have many primips in labor. They would not ask for any pain medication. And then by the time they asked for pain medication, I learned very quickly that means the baby was crowning. And then we're talking 20 minutes of pushing. Like, it was pretty incredible. So those are some of the factors that I think are playing in that. Let's see here. Do these come mostly in active labor? Yeah, so in terms of the rural areas, they come in early, but in terms of, oh, I see what you're asking. Like, do women show up in active labor? Yes, but like I said, I think we don't know yet, or I haven't seen the data if it's cultural or physiological in terms of the pain tolerance. I think, you know, they, like I said, it's kind of amazing to me. I wouldn't hear a peep out of a room with a primip, and then next thing I know, she's in transition, right? And I was like, that is like, I'd never really seen that. And I'd worked in migrant farm worker areas and on other reservations and things like that. And so I hadn't seen it. So I don't think that there's like, maybe they're coming in more in active labor. But I can't say that I would deduce that, because I do remember people initially when I first started, I'd be kind of shocked that they were there so early, but then they would move really quickly, even as primips. Ah, interesting. Melody's saying similar concept when she worked with Amish women. Okay, that looks like it. Thank you so much all for your patience. Like I said, I'll have some of those slides, and those have a lot of the statistics on it and whatnot that I went over, but hopefully you've learned something about how this really important issue in our country can be addressed. I feel like if Alaska did it, any state can, right? We have so many challenges here with access and with the rural nature of things and with weather being inclement and all of that. And so I feel like if we can do it, hopefully it's an inspiration that other people can too. All right. Thanks, everyone. Bye.